Good morning, everyone. Thank you for coming. So, I have no disclosure. We're going to start with a simple introduction, and as Dr. Shatti has mentioned, the first few presentation has laid out the layout of our presentation. So, given the rapid expansion of TAVR in younger patients, attention has shifted now to a strategy in lifetime management in aortic stenosis who need to do initial intervention at earlier stage. And we know now the ability to evaluate the feasibility of future aortic re-interventions has become increasingly important. As we can see from the graph that as we went forward for the last 10 years, there is a significant increment increase in TAVR cases concomitant with decrease in the ages of the patient demonstrated by the green light. So the upcoming 5 years will be interesting to see those patients coming. And the guidelines has been keeping up with that. So you can see even in the North American guidelines or the European guidelines, TAVR has went up to be a class 1 indication in patients with 65 to 80 or above 80 even. But still there were some gray zones like in the picking what kind of valve they're gonna be implementing. As we can see in the European between 60 to let's say 65, there was no consensus of what kind of valve they're gonna use. And also that goes for the American between the 50 and 65, are they gonna use mechanical or biological? So we can see out of the back that there is multiple gaps that has to be filled. So let's talk about the trade-off between SAVR and TAVR. Well, TAVR is, there's been a talk about the paravalvular leak, the pacemaker in the last couple of discussion, but we can see with the technology improvement and the technique, these has been going more and more less. What about AF? Less than TAVR, bleeding, less, renal failure, less, hospital stay, less with TAVR. And the durability, now we know that it's at least more than 8 to 10 years. Now, the only hot topic that we have some trade-off, we have to think about is the coronary accessibility and the re-intervention. But we can know that all the trials and the data that support the notion that there is no difference between TAVR and SAVR up to 5 years in high risk and in intermediate risk, and no difference between them in low risk cases up to 2 years. So this is where the role of the heart team has evolved and became multidisciplinary collaboration is very the key for having a successful approach to the patient. So we have to cover a couple of concepts. Number one, you have to plan your second intervention at the first intervention. So let's say you pick to go with a SAVR. So you have to consider that doing a redo SAVR has a higher mortality in 1 month and 1 year. But if you have a TAVR in SAVR, your mortality will drop straight ahead to 2% to 5%. But if your first intervention was TAVR, then you have to consider that your second intervention, if you went with an explant and another surgery, your mortality will go sky high, ranging between 10 to 30%. But if you went for TAVR and TAVR, your mortality will substantially go down up to 6%. So the TAVI repeatability will be likely most frequently as a second intervention in a lifelong strategy. What about the second concept? Well, what kind of valve are you going to take? Are you going to take a short stent valve or a long stent valve, balloon expandable or self-expandable? We know to some extent that durability so far, we're talking about 8 to 10 years. But my second intervention, if I'm going to go with a SAVR, let's think about my explantation and what kind of, it's going to be involving a root replacement. And if I put a long stent frame, we have to talk about coronary accessibility with the second TAVR intervention. So TAVI repeatability might be as important as leaflet durability. I'm going to focus on a couple of stuff mainly because the other three has been covered already, which is the coronary accessibility and patient prosthetic mismatch in TAVR in specific. So how can we achieve these with good results and minimal risk? By understanding the anatomy of the patients. So few points. We start with the cusp overlap. It's not only selected to the self-expandable valve, but also balloon expandable valve because it showed display it open the non-coronary cusp, it's more oblique, and turn at the nadir to show exactly. What are the advantages? It eliminates the parallax, it delivers the catheter more central, and the deployment in the true coplanar view. And short visual distance for the self-expandable to engage the non and the left coronary cusp. And now more focus on the commissural alignment. Now, because we were talking about coronary accessibility, your favorite alignment should be here. Like you don't want your commissural to be exactly where is your ostia of your coronary. And we know that PCI in patients with ACS in general after TAVR substantially became more difficult, especially with long stent frame TAVRs. And it's not far away with a short stent frame TAVR. So why are we talking and more focusing on commissural alignment? Because improve the hemodynamic performance due to balancing of the flow dynamics with neo-sinus, reduce the leaflet stress, improve the long-term durability and longevity of the bioprosthetic valve. It understands the access for the coronary ostia with the PCI and the ability to undertake the basilica procedure for future valve-in-valve. So this is a new thing is happening now, which is the Octa-Align. It has not been implemented in the region, but you have to take that in consideration in balloon expandable valve. So I'm going to go with the valve. The whole notion after you go with it is like after the deployment of the valve, you want to be using the Octa-Align method, okay? You're going to have minimally misaligned the commissure with the ostia of your coronaries. So here are your commissural here. And here is your coronary. And this will make it more easier for coronary accessibility. So native commissures be easier to be accessed. So it's morely based on your CT analysis. It's not has been implemented yet using the 3-menso CT, but basically you take it from the mid sinus of Valsalva, you identify your cusp, and then you identify your geometric nodule of sinus by having a perpendicular lines, and then from this line, you direct your clock angle, where is exactly identify the corresponding, let's say the right cusp. So, and now you have your clock angle, and they have their own crimping. Well, I'm not going to go in detail, but it's a bit complex to understand, and you have to go through it, but even there is for the bicuspid valve. And you have this one, this is like a flexion just for we're talking about the MyVal, and specifically in this technology in Octa-Align, and it will give you, and you have to maintain your precision irrespective of the clock angle. So now you have your clock angle, and when you crimp your valve, you have your angle to go with it. So your whole notion is to have a perfect alignment of your commissure based on your CT and based on your crimping. So here you are, you're crimping the valve and making exactly where you should be and exactly where you should commissure align when you introduce the valve in the patient. This is the final confirmation of your angle. And once you go there, you don't change anything. You maintain mirror up, you maintain the line up, and you don't rotate anything as you introduce the valve inside of the patient. And this is how you don't move it, go in, and with the Octa-Align alignment technique, just control everything so you have perfect alignment once you deploy the valve. So moving on, let's talk about mismatch, because we know that the balloon expandable might have an issue with that. So this is a nice study, has been comparing a couple of 100 patients, Sapien versus MyVal, to see degree of the safety profile and the outcome. They have noticed that there is a lower need for new pacemakers with the MyVal, possibly extrapolated that maybe they have intermediate sizes so you don't go overboard or underboard. But there was no difference in the hard endpoints in terms of the mortality or efficacy or early safety or even in the degree of aortic regurg. And finally, you have to know the device-related factor that predisposition for the increasing the risk of coronary accessibility. And this has been mentioned this morning in the CT analysis in relation to the sinotubular juncture, the design of the device's leaflet, and the depth of implantation. So you have to plan everything from the first valve implantation. What is your target? How far I'm going to go down? How far I'm going to go up? And how you do that by understanding your CT. As you can see, if you're going to go in the future, if you're going to go balloon expandable usually is going to be the same size, outflow to outflow, and usually consideration for overexpansion if there is a paravalvular leak, and lower implant if a coronary risk is there, especially if you have a narrow sinuses or low STGs. But if you're going to put a balloon expandable and evolute, well, the sizes might go a bit lower, and the outflow should be at the nodule 4 or 5 and the self-expandable one. But you have to consider some sizing, and you have to go to the original CT of the patient. So with that, we're going to go to a recorded case now. Could we please up in a second? So this is an 85-year-old gentleman who had a normal coronary, has multiple comorbid in the past. His ECG looks normal for us, is like normal sinus rhythm, no obvious conduction abnormality. His hemoglobin within normal. He has lots of medication at home. His chest X-ray is within normal, even his coronaries. But he's also showing 55% ejection fraction with an area 0.8 and a high velocity when the gradient almost reaching 60. He was consensus in the morning meeting with the combined meeting, and we went with the choice due to the age and combining with our own guidelines that the patient should go for a TAVI procedure. So as you can see here, he has some calcification and some tortuosity in the periphery. But you can see in the area as it's demonstrated, it is 476. You have good diameters, your parameter is good, your heights of your coronary is good, your sinus of valva 27 and above, and STG almost 27 also. So when we put the sizing in here, the patient lay nicely here comfortably in the 26th frame. But you can have also other options for patients. You can go even, if you want, you can go for 24.5. So we decided to go for a MyVal 26, right femoral access using a ProGlide, and we decided no need for pre or post dilatation. Can we get the recorded case, please? Recorded case, please. Play it. So the case should have been with an audio, but for some technical reason, we couldn't do it. So it will be silence, and we will be commentary on it, okay? So we have been having now, this is the right femoral axis, as you can see here. In my center usually, or at least for me, I go with a contralateral angiographically guided axis for the TAVI. So I would like, Dr. Shatli, what do you think? What is your usual one? You go with the angiogram, or you go with the micropuncture or ultrasound guided?
What do you think, Dr. Wan?
I do both. Actually, you know, like we used to do it in this old-fashioned. Then recently we started to do it with ultrasound guided. I think it is like decrease the risk of complication when you do it under ultrasound guiding.
Yeah, the ultrasound, the difference in the successful access is successful in all of them. But what's the difference in the ultrasound is to select the spot where the calcium is less to hold the closure device. This is maybe makes the ultrasound is superior to the other. But all the three ways are acceptable. The micropuncture, you do it. Then if you are not happy about the position, take the needle out and select another position and go with it. But at the end, either angiographic guided or the micropuncture or ultrasound, all the same. Once successful is successful. And if the complications happen, it will happen with all. But the selection of the closure device, improving the skills with the post-care is very important, and the planning from the beginning.
What about pre-closure?
So this is it. In my case here, we can see that I picked as a closure element, I'm going to use 2 ProGlides and plus minus angioceal at the end, depending on the situation. There wasn't much of a calcium, there wasn't much of tortuosity or a high puncture, but I would like to see the show of hand of here people who are happy to go with a suture base or a plug base. I don't know. Who from the audience go with a 2 ProGlide plus minus angioceal? Show of hands.
So 2 ProGlides, option 1. Who would go for 2 ProGlide from the first? Okay, that's good.
1 ProGlide.
1 ProGlide.
Angioceal.
Sometimes. So sometimes is when? Small ladies or small legs or?
No, I found it also very, very good strategy to do 1 ProGlide, but you prepare your angioceal. Some of our colleagues, they don't even do angioceal. They go with 1 ProGlide and they do some pressure. Yesterday, with Accurate Neo 2, the access was good. I did 2 ProGlide. That went okay. The other side, like angioceal, and we removed the pacemaker and the cath lab. Even the distance between the left main and the baseline of the sinus, it was like 7, and it went okay. But it depends on the patient. If you have a clean groin, I mean a clean artery, not calcified, and you are not using 16 French, it's 14 French. With most of the devices, we have 1 ProGlide plus minus angioceal will work.
Very nice. Anybody does two per glide, deploy one, check if there's no bleed, doesn't deploy the second, or doesn't matter at that point? Some people. Okay.
Anyone use plug-based like the F14 French or 16 like the Manta? Okay, one, okay.
Early adopter.
Yeah. So I think most of the people here, like with TAVI operator, they are more comfortable with going with two proglides at least, especially in case if you have an obese patient or you have a difficult to some extent puncture, and then you can complement it with an angioceal or a plug-based 6 or 8 French, depending on your patient's common femoral anatomy and size. So as you can see here, I'm now removing the last proglide. And we use usually here extra stiff straight wire to have more stable. And now we're going to introduce the Python sheet, which is 14 French for the MyValve. The beauty of this sheet that it can accommodate all across the board of the sizes, starting from the 20 and up to the 34. So it's unlike the computer for them that they don't need to have like 114, 116. It's just one size fits all. So I would like to be hearing from the panelists. How do you feel about this? Like, does this make it easier, difficult, or does it make a difference? Dr. Abdurrahman?
Yeah, maybe the only difference with the larger size valves is to predilate with the introducer or the dilator 18 before you push to minimize the resistance over the valve while pushing. Otherwise, is the case. Small valves less than 26 can go easily with just reasonable resistance.
Okay. Dr. Wael?
I agree with Abdurrahman. You know, sometimes when you have to look at the CT. The CT, it gives you all the information you need to predict what's going to happen. So if I have a calcified lesion in the iliacs, and I expect that the device will have resistance to go in, then we pre-dilate, we use shock wave, or sometimes we dilate the sheath itself with the balloon. There is a nice paper by Gilbert Tang and his group, and actually you can't even know what is the size of the balloon to use for that sheath. So it's very interesting, and the most important thing is ahead of time you plan rather than you stuck during the procedure.
Yes, agree. So after we did that, you can see this is the crossing of the valve using a straight wire and amplats, and followed now with using a confida wire for stability and introducing. I know some centers like to exchange at this stage and put a pigtail to exchange the wire, but I don't know about the others. What do you think? Show of hands, who likes to use a pigtail to exchange? Okay, still not much. And who goes straight ahead with confida? Yeah.
It depends on the LV size, to be honest.
Okay.
If it is generous, we're going to go ahead immediately. If it is small, we'll use the pigtail.
Okay. So in my case here, we have decided that we will not predilate. The calcium wasn't significant, and the area wasn't critical, nor the gradient was a critical area, so we went with the guide. You can see here I'm pushing the 26. It needs some push, to be honest with you, and but again, it can go, so don't take it lightly. But here you can see we're introducing, and at the same time confirming the wire position. Now, this is the beauty of this valve, that you don't have to reload the valve. You just go straight ahead, and there is only in the pictures that I show you in the presentation, if you need to flex, it's just one wheel. There is no mid-flexion, no maximum flexion. You just go, and you can see I didn't even need the flexion here. I'm just pushing the valve, and someone is using for me, holding for me the wire. You have 3 dots, as it's shown here, and 4 dense and 3 light markers, which help you in terms of your positioning. At this stage, we already have decided which position we're going to put the valve, and we did the aortogram, and now we're pushing the valve down to have our final confirmation of the position. And you can see I'm confirming everything here to make sure, and I think I'm going to do a test here or an angio. Yes. So we can see we're exactly like at the second dense line, which is usually your target here. So my target here was, as the patient was almost 87, 86, my target is to avoid here with rapid pacing, and I'm holding with my wrist or my elbow with the right the valve, and at the same time I remove the pigtail. And then we have inflated it at rapid pacing. You can see there is a complete zeroing of the pressure. And now we did inflict, so there wasn't an issue, but we have removed the valve very nicely, simply. And I just was telling my assistant to decrease or make it more negative because I felt the valve still needs some negative here. So this was my approach in terms of the valve. We have the nice thing, we didn't need to load the valve. The positioning was easy with the markers, but it's the same concept about rapid pacing. My depth in the valve decision was based on age of the patient, and my target here was to avoid pacemaker rather than to plan like a second TAVR in the future because his age, basically. So I don't know, what is your take on this point now, Dr. Shatli?
Well, that was a nicely done mass release, to be honest. The placement of the valve was well done. It's 80-20 placement.
Almost like 90-10%. Are we going to do an angio now shortly?
Yeah, we can move on.
But we were waiting. As you can see, the dynamics of the patient was like, recovering from the rapid pacing. We don't like to go straight ahead and do an angio, give the patient a couple of minutes just to recover from the rapid pacing. And here we go. I think we're waiting for it. We're having just to remove the parallax from the picture. While I'm removing the valve, we're introducing this. I think we're going to do an angio shortly here. There you go.
Very nice.
Yes.
Beautiful.
Beautiful results.
So it depends on what is your perspective here. In my case, in particular, my target was to avoid a pacemaker in him and doesn't go too much. I have a good sinus. I had a good coronary height, so we were fine that perspective. But if I had a younger patient, I would have went lower a bit for a future intervention in the future. So that's the only difference in this situation. So I don't know, what is your take, Doctor, the panelists and even the audience?
Yeah, so giving a patient, like young patient, you have to be very careful with the conduction or abnormality. We used to just, like when we start practicing, we just, want to leave the cath lab, put the valve, and now we are seeing at this time of our practice, a patient who had left bundle and pacemaker, they are really not doing good. They are coming with recurrent admission, with a heart failure. So conduction abnormality is really not good, as the paravalvular leak. So you have to exercise yourself to give the best result when you use the TAVI. So it have to be, like I know there is a lot of surgical people here, it have to be like SAVR in regard of the heart block and the paravalvular leak. Young patient, 65, and you give him TAVI with the left bundle or pacemaker is really bad.
Dr. Abdurrahman, you have any comment?
It's okay, but in regard of the pacemaker implantation and the collective evidence, it's a therapy. It does not increase the mortality significantly compared to the other complications. Not like a BVL, which is associated with significant if it is more than moderate. But the pacemaker is a therapy. And if the patient is requiring a pacemaker, that means he is predisposed. He has the risk factors from the beginning, either atrial fibrillation, baseline, bundle branch block, the junk of calcium at the conduction system. So they are at risk. And the techniques to minimize the artificial or acquired from the valve is maybe by adopting the cusp overlap view and adopting the high position, minimize the need for the pacemaker, but increase the risk on the coronaries. So going higher with the valve position, especially the self-expandable valve, it may go up to the sinotubular junction, which is the source of the coronaries perfusion. For the future, maybe valve and valve, access of the coronaries. So the coronaries is the lifelong, not the pacemaker. The lifelong management probably is the coronaries work and the need for the future valve and valve.
We are getting ready soon for the live transmission, so.
Yes, so you can see we did the final picture and the groin looks good, so we concluded the case, I think.
Yeah.
Because we have now-
Thank you very much.
Yes,
That
thank
was
you.
very useful.